One of the things I wanted to talk about was when women have radiation injury from treatment for gynecologic cancers. The most common gynecologic cancer that women are treated for is cervical cancer, but they can also sustain injuries to the urinary tract when they get treated for conditions such as endometrial cancer or ovarian cancer. These injuries in rare circumstances can be severe and need a reconstructive urologist. One of the things that I really want to accent is the importance of radiation in the treatment of gynecologic cancer. Patients with these conditions, unfortunately, are often very young, even sometimes in their late 30s or 40s. And radiation is essential in order to cure these women of their life-threatening cancer. The types of damage that can occur in women after radiation therapy for cervical or other types of gynecologic cancer are pretty varied. Some women can have damage to the bladder, which we call radiation cystitis. The way this manifests itself is with bleeding in the urine, a lot of irritation, and contraction of the bladder, where women don't have a very high volume. The other types of damage that are very common after radiation administration during cervical cancer is damage to the ureters. The ureters carry urine from the kidneys to the bladder, and they travel through the pelvis on either side of the bladder. Unfortunately, they travel very close to the cervix and also to the other pelvic structures, and the radiation dosages that are needed to treat cervical cancer successfully can cause scarring of these ureters. When the ureters get scarred, the kidneys swell and patients lose their kidney function. They often have to have chronic stents in place, which are small plastic tubes that travel between the kidney and the bladder. These plastic tubes are changed every 3 months to a year and can effectively drain the kidneys in most cases. However, in some cases the strictures are too tight and the kidneys don't drain very well with these stents or plastic tubes, or patients don't tolerate the stents very well. The reasons that patients don't tolerate stents might be a lot of irritation and swelling in the bladder. This can cause patients to feel like they need to go to the bathroom all the time, or they can have chronic pelvic pain from the stents rubbing against the inner surface of the bladder and causing essentially a sore or ulcer on the inside of the bladder. The stents can also cause a lot of pain in the flank or the side where they travel up to the kidney underneath the rib cage. The way this feels is especially when women urinate, they get a sharp pain in the kidney or a crampy sensation in the kidney. It can be very similar to the sensation of having a kidney stone. This can be also very bothersome for women. Another problem that women can get is chronic urinary tract infection. And this can arise from the foreign material being in the bladder in the form of the stent or the irritation that the stent induces in the bladder wall. All of these factors can create a situation where women aren't tolerating chronic stents, and in these circumstances, reconstructive surgery is needed. The types of surgery that are done depend on the extent of the ureteral scarring that's present. Unfortunately, often the ureteral scars are very extensive when radiation damage has been encountered from treatment of cervical or other gynecologic cancers. Small scars can be treated by simply cutting out the scar tissue and reattaching the ureter to the bladder. But longer scars, which as I mentioned is often the case, extend out of the pelvis, above the great vessels of the pelvis, and towards the kidney. In some cases, more than half the ureter is scarred down from either previous surgery or the extent of the radiation damage. When the scarring is extensive like this, we have to do a lot of other surgeries in order to establish a connection to the bladder. Sometimes we can create a large bladder flap, or we can mobilize the kidney so that we can pull it down from the abdomen a bit into the lower portion of the upper abdomen and create a situation where we can bridge a larger gap. In some circumstances, though, we have to substitute something for the ureter when extensive scarring has occurred. The most common substitution that we perform is using a piece of the bowel. The small bowel has an inner diameter of about my thumb. The ureter has an inner diameter of approximately a Bic pen, although often when they're scarred, they've swollen up a bit and they may be as large as my pinky, for instance. So when we substitute for a bowel for the ureter, we often use a small bowel. It creates a very large ureter that can travel all the way from the kidney down to the bladder if necessary. And also we can use this bowel to substitute for both ureters if both ureters are scarred, which is often the situation. This is called an ileal ureter. In some circumstances, we can use the appendix to substitute for a smaller portion of scarred ureter, especially when the ureter is on the right side. The appendix approximately has the same lumen or the same diameter or is the same size as a native ureter. And so we can sew one side of the appendix into the bladder, disconnect it from the large bowel, and sew the other side of the appendix to the non-scarred ureter in the upper abdomen. This is called an appendix substitution. The other types of complications we see with radiation damage from treatment of gynecologic cancers is what we call a vesicovaginal fistula, which is a hole between the bladder and the vagina. The tissue between the vagina and the bladder is very thin, and when radiation damage, particularly with previous surgery, occurs, then a hole can rapidly develop between the two. If the bladder is normal and the urethra is normal, these holes can be sewn shut, often with some local flaps in order to plug the hole and bring in some fresh, healthy tissue. Depending on the nature of the injury, sometimes these holes cannot be feasibly closed. A circumstance, for instance, when a hole could not be closed between the bladder and the vagina would be where the bladder has lost a lot of volume and become very contracted due to the radiation damage. Or sometimes the urethra is not usable. These urethras can be damaged from previous surgery or also from the radiation injury. They become fixed and open, and there's not much that can be done to improve natural voiding from the urethra. In these circumstances, sometimes the bladder needs to be removed, and patients need to undergo something we call urinary diversion. This is where we create a simple stoma for urine to drain out into a bag pasted on the abdominal wall, or we create a new bladder, which a patient can catheterize via a tiny stoma that sits at the base of the belly button periodically in order to drain out the new bowel bladder. I'd like to share some slides with you now about some recent cases of ureteral damage that we've seen after gynecologic radiation. The ureters, unfortunately, are one of the most common injuries that we see, and we have to do various things, as I mentioned previously, in order to establish a connection between the bladder and the ureter. I'd like to share some slides with you of some recent cases of women that had problems after radiation for cervical cancer, specifically ureteral problems. In some of these slides, there are some operative photographs, and so I would be cautious if you're a patient with these problems. Some patients find that these slides are very helpful to understand the types of surgeries that might be needed to fix their problem. Other patients find that they're very anxiety-provoking. This is a slide from a colleague of mine at University of Minnesota, Dr. Elliott, that he presented in a recent presentation. And I find it a very useful slide. It shows the rate of complications long-term in women undergoing cervical cancer treatment with radiation. And what you can see, these are a bunch of different treatment types, but any combination of treatment with surgery and external beam radiation, or two types of radiation, such as brachytherapy, which is HDR, plus external beam radiation, had the worst complication rate. And the serious complication rate was 30% of women at about 10 years after therapy. So a very high rate of ureteral injury and other serious urinary injury with cervical treatment with radiation therapy. This was a recent case that shows bilateral involvement of the ureters. Here you can see the ureters coming down from the kidneys up here towards the pelvis here, and they're very swollen down to where they scar down. Here the scar starts here, and the bladder sits clear down here. So you're talking about several inches of scar. Here there's a big abscess or pus cavity down in the pelvis next to the bladder where the ureter has been destroyed and there's some chronic urinary leakage. Here you can see that pus cavity rather clearly, and you can also see the gap between the bladder and the ureters. There's no way to stretch these ureters all the way down to the bladder. You have to find some other method of bridging this gap. And the usual way we bridge this gap is with what we call an ileal ureter, which is using small bowel to connect the kidney to the bladder. Here you see another patient that has the kidney here, and then this is the ureter, which is a piece of small bowel. Amazingly, the small bowel adapts very well to being the ureter. Some patients may have a little bit of mucus within their urine, but they rarely have urinary tract infections or chronic problems with the bowel being placed into their urinary tract. Here's a lower portion of the ileal ureter, and you can see this piece of small bowel coming down to the dome of the bladder and being plugged into the bladder. This can be a very effective way of managing this problem without chronic long-term stints, which some patients don't tolerate. This is a patient from earlier, and you can see this is post-operatively, and we have the two ureters here, which are not nearly as swollen, and then you don't quite see the ileal ureter quite as well as the previous patient, but there's a piece of ileum that connects up down here, and then there's another piece that runs up to this ureter, creating a Y in the abdomen that travels down to the bladder. This patient has done very well post-operatively. She's free of the stents, she's been able to gain weight back, and she feels back to herself before surgery. Not all of the outcomes are as perfect, but this is a good illustration of the type of a return to normal life patients can experience if they're having problems with ureteral stenosis after radiation therapy. Here's another case of a patient that has scarring of the of the left ureter. This is a patient that's on her back, and so this is the left side. And the scarring starts right here at the pelvis, right about at the top of the iliac wing. So it's a pretty extensive scar. In this case, the patient had a very healthy appendix, which is depicted here, coming off the large bowel. And we were able to rotate the appendix over to the left side and substitute it for the ureter. The nice thing about using the appendix is that it's small caliber and has a more normal diameter or size compared to the ureter, compared to small bowel, which is quite a bit larger. Here the ureter has been sewn up here towards the kidney. It's coming down in the pelvis, and between these two stitches the bladder has been pulled up and the ureter will be sewn to the bladder. This is a temporary stent that will be put in to allow for ureteral healing. This is the x-ray in this patient post-operatively. She also had bilateral or both side ureteral scarring. On the right side we were able to pull the bladder up, and on the left side we used the appendix to substitute. You can see the appendix kind of stops right there, and then it comes down here, the stent's in place, and it's sewn in place here. That's the end of these slides on some ureteral complications that we've seen recently in patients with gynecologic cancer. Treatment of radiation injury can be very challenging. Often patients have been told that there's nothing that can be done, and in some cases that may be true, but in a lot of cases seeing a reconstructive urologist can help, and you can get a thorough opinion about what the options are to treat these very severe problems. Often we can come up with a plan that involves surgical correction of the issues, or at least we can tell you your options. Surgery usually is not easy to treat these problems. Patients have to be good candidates for surgery, and sometimes the damage is so severe that the urinary tract is not salvageable, and for instance we have to remove the bladder and create a new bladder or a simple stoma to divert the urine. But usually patients are much better after these procedures if they're dealing with chronic urinary leakage, chronic pus pockets in the pelvis from the radiation damage, etc. If you'd like a second opinion about how we can help, or your urologist has suggested that you see a reconstructive urologist, I encourage you to come down to the Center for Reconstructive Urology to discuss your issues and what might be done to manage them. I'm sure we can come up with a logical plan, or at least give you very good information about the extent of damage and what the options would be for handling them.